So now that we know normal, let's talk about abnormal patient vital signs and signs that we should be concerned about with their vital signs. Anybody that's got hypertension, I don't test on numbers or anything on that order. Just know you're greater than 120 over 80. And these are the new guidelines. I don't know which year. I think these were 2017 also that these came out. So if you've got somebody to 130 systolic to 139, over 80 to 89, that's called hypertension stage 1, and organs can be damaged with this. This is really tough on the heart also, having to work and push through these blood vessels. Stage 2, they've got a blood pressure of greater than 140 over greater than 90. Now, some patients are going to come in nervous, but if they've not taken their blood pressure medications and they've got a blood pressure of, say, 199 over 102 or 140 or something on this order, we're going to be really worried about that. And I would cancel the patient that day. There's no way I would treat somebody with a blood pressure like that. Then a drop in blood pressure is hypotension. A lot of times the patient will faint or pass out. And then let's look at some abnormal EKG patterns. We saw that normal sinus rhythm was a P before every QRS. You can see that the beats are regular. And so this is for an adult. For a child, which is usually 8 or less in age, we start to call a patient an adult when there's breast development or if there's armpit hair development. So usually that's about age 8 or so, they're considered adult. But for a young child, especially the youngest child, is going to be over 100 beats per minute. And believe it or not, we call that a sinus rhythm, even though it really is a rate that is normal for that patient, and it's over 100. So we've got to look at the patient and how much oxygen their heart is consuming with a rapid heart rate. And we talked about that earlier with the amount of time for diastole, for the heart to get its fair share of blood. Because older patients are going to have atherosclerosis, they're going to have really fixed artery size. They're not going to be flexible. They may not be getting enough blood to the heart muscle. So there's a blood perfusion mismatch, it's called. Some patients, even with a slow heart rate, if they're very athletic, like we see with Chuck Norris here, his normal resting heart rate might be in the mid to high 40s because his heart muscle is so strong. So, say he's a 48 heart rate. With a child at a 48 heart rate, a newborn, as you see in this, that is considered cardiac arrest, and their patient has imminent chance of dying in that case. So people under 8 need fast heart rates. And we don't want ultra slow heart rates also for the adult patient. They could be having hypotension, which is the drop in blood pressure, and approaching cardiac arrest. This is the dysrhythmia. Notice I call it dysrhythmia as opposed to arrhythmia. Some people will use arrhythmia, but to me, if you're using arrhythmia, that means that there's no rhythm, where dysrhythmia is a dysfunctional rhythm. So this is atrial fibrillation, nicknamed AFib. You can see that there's a bunch of crazy looking P waves there because of where the leads are placed, and that the ventricles, their QRS complexes, have no rhyme or reason. And they have their own intrinsic firing. They will fire without a P wave reaching them. So notice that it's also a chaotic QRS complex. They're not spaced well. There's no talk between the atria and the ventricles. These are premature ventricular contractions. Notice that they are kind of upside down, and this is an abnormal beat of the ventricles. The next slide is ventricular tachycardia. This is a lethal rhythm. It needs to be treated with your CABDs, early defibrillation, start circulation right away. This is a 911 call. I like to show you on a normal EKG while we were putting in an AICD for the patient. toward the left of center, you'll see real VTach. Then there's VFib, which is just a quivering of the ventricular muscle. No blood's being pumped. The patient is about to go flatline unless we intervene, and then hopefully luck will be with us. ACLS does not in a lot of cases work, but we still have to go to try and resuscitate the patient and follow our CABDs. So this is VFib or ventricular fibrillation. Then the patient will go to an agonal rhythm, and then they'll progress to flatline, which is death. With breathing, we've got rapid breathing, tachypnea, dysfunctional breathing, slow breathing, dyspnea, bradypnea. No breathing is apnea. That's usually due to obstruction. Obstruction, the big obstructor is the tongue, and you'll see as the diaphragm contracts, and then there's no expired gas, they will be in a rocking horse type of pattern because no gas is moving. If there's crowing, wheezing, snoring, the patient is barely squeaking air by, and again, silence is total obstruction. Wheezing, if you're listening to the patient, is narrowing of the bronchioles. So we've got to be able to treat that then before we treat the patient. And you'll see in other lectures that is treated with coughing and deep breathing or with something like albuterol or Primatene Mist. Aspiration is a really good chance of death for the patient, so it's got to be looked at as something really crucial to not happen. That's why NPO status is so important. This is where gastric contents, stomach contents are emptied into the lungs. Let's look at end-tidal CO2. So as a result of all those chemistry reactions that we saw in the body, we saw that the cells use glucose, they use oxygen, they make ATP, which is a gasoline, adenosine triphosphate, that the muscles use and such, but that in that reaction, CO2 is put out, carbon dioxide. So let's look at then end-tidal CO2, which means the end of breathing CO2. It is a standard monitor now. It used to be optional, but now it's mandatory. So there's two types of systems. If you look at this gentleman wearing the mask, you notice that there's chance that he's going to entrain or bring in room air. So that's called an open system. The person breathing the nasal cannula, they're also breathing in room air. That's an open system. If someone's got an endotracheal tube or an LMA or a King airway, that is called a closed system. They're only breathing the gases that we're giving them. So the normal capnographic, which is the tracing pattern, is if there's no CO2, they're probably taking the breath at that point. As they exhale, CO2 is going to climb until they finish exhaling. Then they're going to take their breath and CO2 is going to drop down to zero again. So we look at that pattern. Notice that the end-tidal CO2 pattern looks like hills and valleys. That's an open system. Where a closed system, it's going to be square or rectangular waves in what we saw above when we were describing the capnographic wave. As far as temperature goes, if we're shivering, our muscles are shivering and using oxygen that I would rather have go to all the other cells in the body, not to the muscles, to be used, that oxygen being consumed for other things. I want them to go to the organs. So we want to keep the patient normothermic, normal temperature. And that could be preventing their getting cold with a blanket. It could be an electric heating pad. With abnormal SpO2 readings, it could be because of the position of the sensor on the digit. It could be a cold digit. If there's not a lot of circulation there, we've got to have pulse by that probe, that infrared and red, those diodes that we saw in those lights. Fingernail polish can block it, and we can turn the probe sideways so it shoots through the finger that way, or put it on some kind of other thing like a toe or the nose or the earlobe or whatever. And if there's no pulse, there's not going to be an SpO2 reading. Remember that you've always got to be with a patient. Remember the number 3 for why you've got a supervised patient that are under sedation. As far as blood pressure goes, the cuff has to go at least 80% around the arm. Ideal is 80%. So when you start to wrap it and you've got the Velcro in your hands, you want it to go 80% around the arm. If it's too large and it goes way around the arm, the blood pressure reading is going to be artificially low. And if it's too small, the blood pressure reading is going to be artificially high. Make sure you know how to practice Korotkov sounds. Take and read that over. You'll see that in the slides here. Each of you should be able to perform manual blood pressure readings and know what the Korotkov sounds are. As far as pulse, besides the EKG, we can monitor pulse in the femoral region, and that's where we go when we're down in the groin area because there's a large iliac artery there that will give us a pulse reading. Of course, you're taught in BLS the carotid pulse, and then there's the radial pulse on the thumb side of the wrist. Notice that we said that there is the EKG. I would know where each of the different 3 leads go. The white over the right, and then the smoke above fire. Respirations we can monitor with a precordial stethoscope, listen to their breathing and record it. Temperature, the only time you really have to record temperature is if you're doing a general anesthetic with an inhaled agent. But I'd just like you to see that there's ways that we can plug into the monitor with these different probes or with a liquid crystal diode over their forehead to monitor their temperature. So just keep the patient warm, not overly warm, but just normothermic. And look at the patient that they're pink, their skin is pink, lips are pink. If you pull their eyelid down slightly, their lower eyelid, that's called the conjunctiva, that's nice and pink, as opposed to these pictures of the patient with the blue lips and the clubbed fingers with the bluish fingers. So we're going to want to look at those things on the patient, the color of the blood, the nail beds, the lips, the skin, how they're breathing, how they're positioned in the chair so that they're exchanging oxygen well. We want them to be in ideally a sniffing position with their head forward, neck up in the air slightly so that they're moving air as best that they can, not slumped or something on that order so that they're not exchanging gas well. So just don't leave the patient alone. As far as monitoring children versus adults, it's as if the human being was 2 different types of human beings. Children are so different from adults. So we're looking at, with the child, they've got a larger tongue, a very narrow airway compared to the adult. They've got a larger head, much faster heart rate, so there's a lot of metabolism and a lot of oxygen demand going on. We know that kids have a lot of secretions. They're pretty juicy. They've got narrow nasal passages, and there's not a lot of FRC in those pediatric lungs. And they lose temperature really fast, especially from their heads. Let's now discuss pharmacology for sedation monitoring people. Know that pharmacokinetics, know the difference between that and pharmacodynamics, is the absorption, distribution, metabolism, and excretion of a drug. So absorption of a drug could be through one of the routes that we talked about earlier. So distribution means that the bloodstream is bringing blood into the extracellular fluid around the cells through the capillaries. They can be absorbed into the intracellular fluid. There can be distribution into the fat, And a lot of our inhaled gases that go through the bloodstream will go into the fat, and then later on, they'll be discharged from that storage fat and then exhaled through the lungs. But once it's reached the intracellular fluid, it can be then also exchanged into the other areas, such as the cerebral spinal fluid, the peritoneum, which is the area of the abdomen, out into the fluids there, and then into the synovial fluid of joints. For a pregnant patient, they can be distributed to the fetus. Metabolism is going to be involved mainly by the liver. There are a few drugs that are broken down by enzymes just within the bloodstream, but the bulk of metabolism for the medications we give patients is going to be through the liver, through the processes of adding oxygen, taking away oxygen, or breaking molecules with water. So there's oxidation, reduction, or hydrolysis. And then we can also add a molecule of the drug, say fentanyl or Versed, and they can be excreted either in the urine or they can be brought through into the intestines, and then we would poop that out. And here is a system showing how through the bile ducts, which involve the gallbladder, that the excretion of those molecules can be brought to the intestines, and then eventually, like I said, we'll poop it out. Or in the case of a soluble drug, water soluble drug, will pee it out through the urine, through the kidneys. Pharmacodynamics, it's got the letter D there, is what the drug does to the patient's body. So does it raise blood pressure? Does it lower blood pressure? Does it relieve pain? Does it dilate the coronary arteries? Just whatever. That's the pharmacodynamics of what it does. Let's look at some properties then of getting a patient off to sleep. We know that, and you read in your lectures, that hearing is the last sense to go. We lose vision, taste, and smell, and pain is gradually lost. But if you're talking loudly or there's loud music in a room, it's going to stimulate the patient up out of their sedation. So hearing is the last sense to go. And nitrous oxide will magnify that hearing. Let's look at assessment of patient position and skin status. Since we're sedating the patient, we have got to take care of them, especially the deeper levels of anesthesia. But anytime a patient's under our care, we're responsible for their position, their well-being, their skin status. So we've got to be careful of anything that could be probing, pushing, tugging on the patient's face. It could cause trauma to the facial nerve. We could get something in the eyes of the patient artificially, something that's bad. So we've got to protect their eyes. We might want to put glasses on the patient, some kind of safety glasses. And then we don't want to hyperextend their neck because it can cause really painful trauma to the neck if we stretch their ligaments or compress their discs to try and open their airway. We don't want to do that. So we want to slightly open them and make sure that they're in that sniffing position. If they've got any tongue jewelry in, we want it out before we even start. If they say they've had tongue or lip jewelry, I've never taken it out, I'm sorry, I won't work on those patients. They've got to take them out because your luck, they would be coming loose. They would aspirate those, and then it would mean a trip that you would pay for, as well as probably a lawsuit for somebody that aspirated something in their nose, their mouth, their tongue, their lips. So when you're positioning a patient, like we see with this fellow in this lounge chair with his feet up, he's in a great position as far as a sniffing position. It looks comfortable to me. He looks comfortable. And this is what you want to see with your patient. You want to see them be comfortable. So when you've got the patient there in the chair, maybe some blanket underneath the knees, something to take pressure off their back, maybe a pillow under the back of their neck by their occiput to get them into that sniffing position. And we don't want them to cross their legs. Patients, as they fall off to sleep, will do that, which is going to decrease the circulation to the legs. So the legs should be apart and they should have something underneath their knees to take pressure off and provide circulation down below. But if they do cross their legs, they can develop venous thromboembolism. Anytime we have blood that is not circulating well, that is stagnant, we can develop a clot there. And some of these clots can lead to severe injury or even death. So venous thromboembolism is also known as VTE, venous thrombosis, DVT or deep vein thrombosis, or a blood clot in the legs. Know these definitions. A thrombus is an abnormal clot in a vein. An embolus is a clot that is moving. It's in a vein, it's broken away, and it's moving along in the circulation. Remember that a vein carries deoxygenated blood to the heart. It's the low pressure side of the system. So when we walk, we're squeezing veins, and we've got valves inside our veins to make sure that the blood is constantly flowing in a circulation to the heart. But being a patient in a chair, especially certain patients, they could develop stagnant blood because their veins are not being squeezed or moving every time we move our legs. So stagnated blood can form clots. It's either a clot, which is also called an thrombus, or a moving clot is an embolus. So the embolus will eventually reach the lungs, going through smaller and smaller blood vessels until it lodges and the patient develops a pulmonary artery PE embolus or pulmonary embolus, which is life-threatening. And we saw that this can be one of the major causes of death in the patient. So who's susceptible to a pulmonary embolus, a PE? Patients over 60. It can be even younger patients, but just generally, somebody with a weak heart, congestive heart failure, previous heart attack, history of stroke, patient with acute respiratory disease, they just don't have good circulation in their lungs, an obese patient, and a patient with a hip or knee replacement. So symptoms of a PE are chest pain, shortness of breath, a rapid heart rate, and coughing up blood. There's ways to prevent a PE, and that would be with leg massage. I would raise the leg over the heart. Of course, the high speed's not running, and then just gently move that stagnated blood. Hopefully it's not stagnated, but move it like the person's walking. Just walk your arm from their ankle up to the top of their leg with the leg over the height of the heart. Let's talk about post-anesthesia patient recovery. During recovery, we're going to crank the oxygen up and we're going to have suction available. Some dental boards require you to have suction catheters, so you would have that in your drug kit, your sedation kit, your cart, or whatever you have, and then a Yankauer suction, which is called a tonsil suction. And then you're going to want to record recovery on your chart. So we'll start recovery there, check boxes, maintain your times up on top of when anesthesia and the procedure started and when the procedure and the anesthesia stop. And then we have to tell on paper how recovered the patient is from their sedation. So we use something called the modified Aldrete score, and we go through and look at the patient's activity, respiration, circulation, consciousness, color, and discharge criteria has to be at least 8 to 10 before we can then safely send them out of the office. And then don't forget to write your post-op note. And then I send them home with another do's and don'ts, so post-op patient list of what they should do and not do for recovery after they've had their anesthesia and their procedure. Orthostatic hypotension is the drop in blood pressure. Normally it's controlled in the body when we get up by our carotid bodies and our aortic baroreceptors in the arch of the aorta. So baro is pressure, and these receptors look at pressure and they will give a brief, very brief jolt to the heart to increase then the heart rate and then the blood pressure for just a few seconds. It's not a long lasting thing to be able to get blood to the brain and especially to all the vital organs. So if you sedate a patient, you're sedating those aortic and those carotid baroreceptors, and you don't want to sit a patient up fast or they could crash on their blood pressure. They'll become orthostatic hypotensive, drop in blood pressure. So it's a brief jolt to increase their blood pressure for just a beat or two to keep blood flowing to the major organs, especially the brain. So your older patient and your sedated patient are going to have blunted baroreceptors and will potentially have orthostatic hypotension, which can lead to them passing out or developing nausea and vomiting and possibly aspiration. So set the chair up slowly and in increments. And you have to be available for the patient in your office for the next 24 hours. So let's talk about the basics of what to do with abnormal vital signs. You have been given with your notes, and I would print them out and look them over and make sure you have those in your emergency drug card in your office. The algorithms that I use to treat a patient in one of the 13 emergencies that are common to dental practice and medical emergencies in the dental office. And I've also given you a quick and dirty cheat sheet for your dentist on how to dose the emergency medications. So before the case starts, everybody's ready to rock. Everything in the office is ready to rock. The patient is tuned up and ready to rock. So the patient's ready, the operatory's ready, monitors are ready, oxygen is available and ready to go. And it's got a full tank or at least a half or three-quarters of a tank, whichever, of oxygen, and you know where the next tank, spare tank is. Suction's available. Meds are available, especially emergency medications. You've got your anesthesia cart or emergency cart nearby, and you're able to communicate with each other. And it's good to use a checklist to make sure you've got everything in place so that you're ready then to treat the patient in your office. I know it seems like common sense, but part of the operatory is ready thing is that we use one needle, one syringe, only one time on the patient. So once you've put the plunger into the barrel of the syringe, you've brought contamination in there. And if the needle has then touched even the outside surface of the patient's IV, it is contaminated. Do not use any of that on another patient. So here we see the picture bringing the syringe into the barrel of the syringe. And just know that you just don't reuse things. So read over these myths and truths regarding the one medication, one use, one needle, one time, one syringe, only one time use for the patient. Know the difference between a single dose and a multiple dose vial and when those expire. For single dose, it's going to be, if it's unopened, the date that is on the label of the medication. If the top is popped on a single dose vial, remember that there's no preservative there and it expires that day. So if it's unopened, again, and it's a single dose vial, it expires on the last day of that particular month. So if it's MAR 2034, that's going to be March 31st of 2034. And remember that the single dose is expired the day that you pop the top on it, as opposed to the multiple dose vial that's got preservative with it. All these drugs need to be drawn up in a clean area. If there's a patient in the treatment area, you should not draw another patient's drugs up there. And remember, like we say, if it's a multiple dose, it's got preservative. So an unopened multi-dose vial will expire on the last day of the month. And if it is an opened vial, you have to then put a mark somehow on it on the day you opened it, and you count 28 days forward, and that's when a multi-dose expires. And just make sure there's no contamination within the vial. And the practitioner should draw up their own meds, especially if they're scheduled medications. They need to be kept with the practitioner and drawn up by them so that they can see what they've drawn up and that there's no diversion that's done by any of the staff or any of the people working around these medications. And make sure while you've got the syringe in your hand that you properly label it, put the concentration, the date you drew it up, the time you drew it up. And I put it sideways, that label, so that you can then see the numbers for the patient. Another thing that we do is to, if it's a multi-dose vial, is to wipe the top with an alcohol wipe and then scrub the hub before you inject it into the patient with an alcohol wipe. So let's look at the 13 most common dental office medical emergencies, and they are the general emergency response, hypotension, hypertension, laryngospasm, acute airway obstruction, cardiopulmonary arrest, allergic reaction to drugs, angina pectoris, in other words, chest pain, possible MI, possible myocardial infarction, emesis, aspiration of vomitus, convulsions and seizures, oversedation, hypoglycemia, asthma bronchospasm, and then respiratory depression. So with the general anesthesia emergency response, you quietly alert just the people involved with it. The office does not have to usually go into chaos. So this is in general. Just the people that working with the patient, the people that need to know are involved with it. Make sure that you position the patient safely. And every one of the emergencies, important to know, are based on the CABDs, circulation, airway, breathing, early defibrillation. Every one of them, that's the backbone for any anesthesia medical emergency that you learned in your BLS class. That's why you have to have BLS, basic life support. Oxygen is one of the first emergency drugs we give the patient, so have that there. And a bag valve mask, which should be maybe attached to that anesthesia cart. Notice that I said call 911, but we should be able to in-house treat 911 patients. So if you see all the above question and one of those is 911, look at that with a skeptical eye because it may not be all the above because we should be able to handle a patient that has passed out. In other words, hypotension. If somebody's had a mild allergic response, we should be able to handle that and not necessarily call 911. And then be ready to listen to and carry out orders. So these apply for every one of the emergencies. So let's talk about hypotension. For your test, will go through and do things to the patient. I'm going to go through steps, and I want you to tell me then, out of a list, what emergency is for the patient. So for hypotension, we're going to want to get the patient into a head down, Trendelenburg position, elevate their legs. You may have to lift them up in the air to get blood toward their brain and their central circulation. Crank up the oxygen, crank off the nitrous, open up their IV fluid to get their pressure up with fluid intravenous, and have another bag ready so it doesn't run out. In some states, you need to have an ammonia capsule there. I really don't use that for a hypotensive patient, but check your state's rules to make sure to see if you need an ammonia capsule. We're going to either use ephedrine or phenylephrine depending on the blood pressure's drop and then if there's a needing to be a boost in heart rate or not. And then cold washcloths then for the patient. So here we are elevating the legs over the head, and there's the drugs that we would give to a patient: ephedrine, inhaled ammonia, or phenylephrine. Some of those drugs are single diluted. One of the drugs is double diluted. It comes too potent. Let's now look at hypertension. Hypertension is a different animal in that we have to do diagnosis for the patient. Some of the causes of hypertension, and they're all treated differently, are due to pain, anxiety, a stroke, heart failure, a myocardial infarction or an MI, or it could be a hypertensive patient that didn't take their meds or they took them at the wrong time. They just didn't even take them at all. Recall the autonomic nervous system, the parasympathetic and the sympathetic side that balance each other. Know that the neurotransmitters on the parasympathetic side are acetylcholine, and then on the sympathetic side is norepinephrine, and that they have two different anatomies, but that they innervate the same organs and they counterbalance each other. One's going to slow down the system, the autonomic system, one's going to speed up. In the case of the sympathetic, it's going to speed it up greatly. What's going on with their innervation of each of the organs? So, for example, with the heart's going to rapidly increase on the sympathetic side, or if there's parasympathetic stimulation, it's going to slow the heart rate way down. With hypertension, the arterial is the primary determinant before it goes in and splits into capillaries. That muscle is the primary determinant of blood pressure. Think of a noose around the arterial. So if we squeeze the noose, we're going to increase blood pressure. If we loosen the noose, and we've got a medication to do that, a bunch of different medications, we're going to drop blood pressure. Know what each of the adrenergic receptors are, what alpha 1, beta 1, and beta 2 do. Alpha 1 is going to, when stimulated, squeeze the arterial in the artery. Beta 1 is going to increase heart rate. Beta 2 is going to cause dilation of the bronchi, which is really good for the lungs. We want those bronchi wide open. So for these patients, as we said, we treat them differently. We have different meds that you learn to use for each of the emergencies in hypertension. Would we consider calling 911? It depends on the hypertensive cause. Do we need to freshen local anesthetic? Do we need to give some more narcotic or non-narcotic analgesic to the patient because they're experiencing pain? Do we need to give a beta blocker that's increased heart rate? Or do we need to give an antihypertensive like hydralazine to loosen the noose? So there's a lot of different causes of hypertension, and there's different ways to treat it once a diagnosis has been made for the patient. There's always a difference. Let's talk about laryngospasm. With laryngospasm, we've got a new way to treat that now, and I want you to see this. We want to get the patient flat in the chair. We want to get the oxygen, but before that, we're going to want to apply Larson's maneuver. Here we are applying Larson's maneuver to a patient. This is going to be a patient that is laryngospasming, and it's going to need rapid then treatment for this. This is a newer method that's come out. We did not learn this in anesthesia school, but I've been told works very well. So think of this as your first line of treating laryngospasm. You, of course, are going to want to suction the patient, but you're going to put your fingers behind the angle of the mandible. That's where the mandible from going horizontal now starts to go vertical, and you push in hard. And it's really uncomfortable for the patient, but that's Larson's maneuver. You'll have a chance then to see with this movie what applying Larson's maneuver is. And if you look at this gentleman that's got his eyes taped, you notice that he's already had Larson's maneuver applied because the skin is red there. So you can see where that is, and you're just going to take your fingers and push in really hard on the patient to break that spasm. If you're going to use oxygen with a bag valve mask, you're going to want to apply it to the face, bringing the face, the mouth, the nose into the mask, and don't forget about the C and the E position. Make sure you have suction there. They've talked about, and some dental boards have you carry succinylcholine. Succinylcholine requires a lot of skill and knowledge to use. There should be other ways that you can break laryngospasm other than using succinylcholine. It comes 20 milligrams per milliliter, and you use only 5 milligrams, so a quarter of a milliliter, but still you need to have a nerve stimulator to be able to monitor it. Something that works better is to use intravenous lidocaine and draw up 5 milliliters of 2%. 2% is 20 milligrams per milliliter. So if you draw up 5 milliliters, you're giving and bolusing real quickly 100 milligrams, and that should then break the spasm also in lieu of succinylcholine. Something new that's come up because of a reversal agent is to use the non-depolarizing muscle relaxant called rocuronium or Zemuron. Again, this requires special teaching and a way for you to be able to do that. Let's look at acute airway obstruction. Make sure that you guard the patient's airway extremely well so that this is a never happening event. You want to get the patient flat in the chair, get them up to your height so you can see them, get the oxygen and crank it up to 8 liters, whatever they've got on. If you need to, use the bag valve mask. Try and get the Yankauer there. If it's deep within the airway, you're going to need to use your laryngoscope and either put in an endotracheal tube or use your McGill forceps to pluck the foreign object out of their mouth and unobstruct the airway. In the worst case, you would do an emergency cricothyrotomy with the kit that you have in your emergency cart. Have your IV fluids full, always have a bag there that's dripping, and have another bag ready to go. So you'll see the patient, if it's just the tongue, with the rocking horse movements that we talked about earlier. But if their patient's deeply sedated or they've got blockage there, we can do a chin lift or a jaw thrust, but we might need to use an advanced airway, and you probably should have those in your emergency cart. And then again, the worst case scenario is an emergency cricothyrotomy, also called an emergency cricothyroidotomy, and a 911 call. Fortunately, there's not any major blood vessels or thyroid tissue in the way. And that's what that kit looks like. It's like a 12 gauge needle that you would puncture through and then hook your bag valve mask up to it. We're getting away from the manual, if you will, analog laryngoscopes and getting into video laryngoscopes now. These are what your McGill forceps look like. The one on the right is a newer design, and the one on the left is an adult and a pediatric McGill forceps, but they should be in your emergency kit. You should know how to use them. Cardiopulmonary arrest is going to be the same as what you learn in BLS and ACLS. That's why we review it every 2 years for each of those. So you're going to want to start doing the CABDs, start pumping on the chest after you've checked for a pulse for 10 seconds or less. Know how fast you're supposed to go, how deep you're supposed to go. Get the crash cart and the oxygen and get the AED on the patient ASAP. You've got to get that on there fast and let it do its analysis. Don't touch the patient during that. Call 911. And then the drug that's used is epinephrine. There should be a number of epinephrines in your emergency drug kit. Somebody grab a piece of paper and chart times. It doesn't have to be beautiful, but just get some things written down so you can chart it later. And then it's a good idea to use your ACLS protocol cards to remind you of what you have to do for the patient after they've had their arrest. So here's some pictures of BLS going on. We've got chest compressions, we've got breathing with the bag valve mask, and we've got the AED in place ready to fire just as quickly as possible, because the patient's going to really deteriorate if they are not using their own heart for circulation. So we've got to get on it. The song you should have in your head is Living on a Prayer while you're doing your CPR. If you don't know that song, go to YouTube and look it up by Bon Jovi. And then epinephrine is our drug that we use now for cardiac arrest. And there's the protocol cards. And just grab a piece of paper. Like I said, it doesn't have to be a beautiful chart. You need to get an IV started if there's not one there. Let's talk about allergic reaction to anesthesia medications. So, allergic reaction to anesthesia medications. If the patient is breathing oxygen, I would take off their nitrous, crank up their oxygen. This might be a call 911 emergency. It's certainly not going to hurt if you've called 911. Open the IV fluids because the patient's blood pressure is going to have plunged, and have several bags ready to go to keep putting it in line. The first medication that you would use, the most important, is epinephrine, if their blood pressure is down real far. Then we're going to give an antihistamine, and there's two types. There's one for the peripheral circulating, the mast cells and the basophils, where we would give diphenhydramine or Benadryl IV. Famotidine treats the histamine that's released from the gastrointestinal tract. So we've got those in our emergency drug kit. And then we'd give hydrocortisone or methylprednisolone, called Syumedrol, to stabilize the leaking blood vessels, the membranes, that the fluids have leaked out because of the allergic response, the severe allergic response. If you see an allergic response, there's a lot of things that can happen. It will be instant rash, rapidly developing edema or lip swelling. And if that swells, the tongue's going to swell, and we're going to be into severe airway problems. The bronchi constrict instead of being wide open, and they get gunk inside of them. They've got secretions and fluids there. The upper airway, as we said, can obstruct, and if it's a true anaphylactic reaction, the patient is going to die, unfortunately, before they hit the floor. So they're going to really drop their blood pressure, and then their skin is really going to itch when they've got their rash that's forming. Physiologically, what's happening is we have an antibody from the B lymphocytes that is responding to something that it has seen before. So the patient has seen this allergen, the thing that's causing the allergy, and we have to quickly get on the treatment for that, because there's just this outpouring of histamine and plunge of drug pressure and rapid airway problems. You're going to want to rapidly open the IV fluids, have other bags ready to hang, because the person's blood pressure is really going to drop from this histamine release from this allergic response. You're going to want to draw up epinephrine, and you're not going to dilute it or everything. You're going to just give it intravenously. Hopefully you've got a bunch of ampules in your cart. Then we're going to draw up the diphenhydramine, also called Benadryl. And don't forget that that's used in nighttime cold medicine. So you're going to not only prevent the histamine release, but you're going to sedate the patient with that Benadryl. It's going to make them very sleepy. Breathing should continue, but just be prepared if they're not breathing when you give the Benadryl. And then give the famotidine. That will not cause the sleepiness or the sedation the way the Benadryl did. Then you're going to want to draw up hydrocortisone, and we showed you how to do that in your lectures, and give that to the patient. And have albuterol or Primatene mist ready to go. Let's talk about angina pectoris. People do call it angina also, possible myocardial infarction or MI. This is a patient's heart that's starved for oxygen. So we're going to want to crank off the nitrous, turn up the oxygen, crank it all the way up, make sure that the heart is getting as much oxygen as we can deliver through the arteries to the patient's heart muscle. Call 911. We're going to want to give something that's going to treat the severe pain that they're having from the MI or the angina pain that we talked about earlier in this lecture. So you can use morphine, which, if you've got in the office, dilates the coronary arteries, or you could give the fentanyl. I would give that. I would not give a non-steroidal anti-inflammatory here like Toradol or any of that. I would not do that. Have the patient chew on a baby aspirin. They could take a by mouth aspirin also. If it's severe pain, they've got sublingual nitroglycerin that's either a dissolving pill format or a spray for under the tongue. Recline the patient. Don't stress them out. You can put a cold washcloth over their head. Just maintain their heart rate and their blood pressure and their oxygenation until 911 gets there. Remember that if you call 911, you're probably going to have to submit a written report to your state dental board. And that's what those meds look like. Make sure they don't outdate, that you're constantly renewing them, and that all your drugs are up to date. Let's talk about emesis and aspiration possibly of vomitus. So we're going to want to elevate the patient's head and rapidly turn their head to the left because of the shape of the mainstem bronchi, the mainstem and then the left and right mainstem bronchi. If you're working with an oral surgeon, the oral surgeons tell the people that work with them that you would turn their head to the right. But the rest of us in anesthesia rapidly get the head up, turn the patient's head to the left. Get the emesis basin, get out your suctions, your low and your high speeds, have them ready to go and working to be able to suction and keep that stuff from going down in and the patient potentially aspirating that. So here we are turning the patient's head to the left or to the right if you're working with an oral surgeon. Things that can precipitate nausea and vomiting are food in the patient's stomach. Patients don't tell us the truth, but if there's food there, they've gone through and they've made a quick stop at the McDonald's takeout, or if they're dehydrated because they followed the NPO guidelines, they could be anxious and stressed. Certain oral or intravenous meds can cause nausea and vomiting, and those are the opioids especially. The smell of the dental office, just from some of the chemicals we use there, zinc oxide, eugenol, or the cleaning agents we use, can just really smell up the air in the dental office. And if the patient's dizzy or lightheaded, they can have that also. So just make sure that you've got the patient's NPO status charted. Have your suction ready and suction all the way down their throat, all the way down past the base of the tongue, and get all that stuff out of there, especially if it's a sedated patient. If they're able to cough and get all that junk out, hopefully they're not going to cough all over you. That's the best way for them to clear it out if they're not overly sedated. So if the patient starts to experience nausea, I would open the fluids, have another bag ready. Decadron is excellent. You've got that in your drug kit. That can also be used for an allergic response, but the other two drugs are used more commonly. Decadron is a great antiemetic, as well as ondansetron. Dentists don't normally use metoclopramide, but what it does is it stimulates the GI tract to move things out of the stomach. It causes gurgling in their GI tract to move things down into the colon. In a rescue attempt, there's inhaled vapors of isopropyl alcohol. So you can rip open a couple of the isopropyl alcohol packets that you got, say, when you start an IV, have them take some deep breaths. And you know that if you've got somebody that tells you in the pre-op assessment that they throw up a lot with anesthetic, that you could then prescribe a scopolamine patch. It's 1.5 milligrams, and it's a little circle that looks like it's on a round Band-Aid, and it goes behind their ear, just on the soft part, like where we applied Larson's maneuver. Let's talk about convulsions and seizures. When this happens, if the person's got nitrous on, we're going to want to turn it off, turn the oxygen up. But if they're convulsing, it's totally all right. And I would take the whole oxygen mask or whatever they've got on their face off so that they don't scratch their eyes, so that they don't get tangled up and hurt in any of the hoses or anything. If you can get the patient on the floor or get them flat in the chair so that they don't hurt themselves, make sure there aren't things like air water syringes or high speeds or hoses or whatever there that they could, if they move, could jar loose and then hurt them. So we've got to protect them. This is a call 911 emergency. You're going to use some of your sedation medications for those of you that are doing IV moderate sedation. Versed is probably the one you're going to have in your office, and you're going to want to just titrate in enough so that the seizures stop. If you've got Valium, Valium is excellent because of its long half-life. And then you're going to want to go ahead and open the fluids. Make sure the patient maintains their blood pressure. Try and see if you can monitor vital signs. Keep them oxygenated and just follow your CABDs. So here we are seeing the patient in the tonic phase where there's just a lot of muscle tone and there's a lot of tenseness. And then there's a relaxation phase where they contract down and they're in the clonic phase. Something that you need to remember too is that the benzodiazepines are used for sedation as well as other uses, but we use them in sedation dentistry for that fact, for sedation. And you've got to consider half-life because something like midazolam that's got a short half-life, it might be 2 to 6 hours, might be chewed up or needing to be redosed is what I'm trying to say. Same thing with a patient that's on triazolam. You can see these cone diagrams showing you how absolutely short some of those half-lives are. Let's talk about oversedation. Oversedation should almost be a non-emergency, a non-event in your office. And the reason is that we titrate our medications. We're going to give them slowly, let them take effect, and then if we need to dose, we'll dose a little bit more. But if the patient becomes oversedated, you've got to get them back into the level of sedation, be it minimal, moderate, deep, or general. You want to get them back to, usually it's from moderate and minimal sedation down to your permit level. So support the airway, follow your CABDs, making sure that there's movement of air. Keep checking and recording heart rate, blood pressure, and pulse oximetry. And then just wake the patient up. This would be where the hearing comes in. So we're going to vocalize. We're going to want to kind of gently shake them and tell them to wake up with a loud voice from us and get the patient back into that level where they should be. And people really respond well to the use of their first name. We have reversal agents for the narcotics and for the benzodiazepines, but they really are rarely used. You should have them there, but you should not be needing to use them because you carefully titrated your doses. Let's talk about hypoglycemia. So this is going to be low blood glucose, low sugar. Symptoms are, and it's going to be really similar to the vasovagal response, are going to be sweating, which is called diaphoresis, jitteriness, nervousness, tachycardia, tremor, altered mental status. They may be talking or vocalizing funny, if at all, and then emesis can also occur. So the way that we treat it is rapidly by giving them a sugary soda pop, a tube of glucose, which could also be cake frosting. Check their glucose with your glucose monitor, and then follow the emesis protocol. We also have in your IV kit a vial of D50 that you can add to their IV solution. Not everybody has that though, but you should have D50 there. So there we are with the cake icing and the soda pop, glucose monitor. Let's talk about asthma bronchospasm. The old adage that an ounce of prevention is worth a pound of cure is especially true with the asthmatic patient. So when you are reviewing their health history, that day that you're working with them with the pre-op assessment, ask if the patient's breathing well, plus you're going to have listened to their lungs. If they tell you that they're not breathing well, have them bring their inhaler. Hopefully they've got it with them to their appointment and have them do some puffs before you start doing their sedation and start your IV and things like that. Consider postponing the case if the patient's not breathing well. You just don't want to experience having to use their inhaler during a case. So make sure they use it properly. You've got that in your instructions in your lecture materials. So some causes of asthma and bronchospasm are pollens in the air, exercise-induced asthma, breathing cold air, dust, animal dander, mold, and certain chemical odors. Dental materials, there's perfumes, lotions, and creams that can cause it. So the way that we'll treat asthma bronchospasm if it should happen during a case is, and again, remember these steps because that will be on your exam, but remember that you can look at your dental algorithms, your emergency algorithms. So you're going to want to immediately discontinue the procedure, get the patient upright, get them calm as you can, get the dental materials away from their mouth, and then have them, if they can do it, administer puffs properly with their inhaler. Get the oxygen tank, if you have to, breathe in their puffs with a bag mask valve and administer it properly. There's also Primatene Mist that hopefully you'll have in your cart for bronchial asthma. And that's what those two inhalers look like. Know how to use them properly so you can teach the patient, so that you know yourself, so that you know that they're getting the dose of the bronchodilator. We've got to get those muscles that spasm relaxed so that the airways open up. They get really, really small as we get down toward the terminal portion of the alveoli. They're tiny little narrow airways. Our last emergency is going to be respiratory depression, and it has different causes. As with hypertension, you have to make the diagnosis so that you know how to treat the cause. So just like hypertension, respiratory depression, again, has a lot of different causes. And they can be due to the over-narcotized patient, this patient that's had too much narcotic or sedation medication. So there could be over-sedation, partial airway obstruction that can be from their tongue a lot of times, or loose tissue in their mouth. The facial muscles relax and they can cause obstruction. Poor patient positioning of their head, neck, their body, their shoulders. Remember, they need to be in that sniff position. It could be from bronchiolar constriction, in which case we're going to need the Primatene Mist there to give them their inhaler. An upper respiratory infection will cause respiratory depression and bad movement of air, especially if they're taking something like Benadryl or something on this order for their cold. It can really depress their respirations. Chronic cough, the COPD or chronic obstructive pulmonary disease, the emphysema patient, the smoker, opioid abuser, alcohol abuser can have respiratory depression. And here are the treatments for respiratory depression. For the over-narcotized, we're going to want to titrate their meds, but if you have to, you're going to use your reversal. You're going to want to, with the over-sedation patient, as we said, wake the patient up, titrate your meds so that you don't get into that. If it's partial airway obstruction, get rid of the substance that's causing the obstruction, the foreign body. If the patient's not in a proper position, get them positioned, help them get positioned in the chair so that they're exchanging air. If there's bronchiolar constriction, we're going to want to go ahead and administer an inhaler. With upper respiratory infection, consider canceling the case as we talked about earlier. Chronic cough patient, I would have them, if they're not taking any medication for it, I would have them cough or deep breathe before you start the procedure. That is a gut-wrenching cough to open up the airways, and then you'll have to allow for if they should go into a coughing fit. For the COPDer, you're going to want to have them see their physician and have them optimize their breathing before they consider doing sedation on them and before you start their dental treatment. Smokers, they have to go at least 8 weeks or longer for their lungs to totally clear off. Just know that there's a chance for them to start coughing if there's a smoker. Opioids and substance abusers are just not at all candidates for sedation in your office. Same with the alcohol abuser. They have got to be clean preoperatively before you can treat them. Thank you very much. Get in touch with your test proctor, who will be Sherry, and that's her phone number, area code 573-303-7635. And you can email her directly at assesslive@hotmail.com to set up your test appointment, your live Zoom exam. Good luck on everything. Thank you very much for taking our course.